So this particular topic is close to my heart, and it's an area, I mean, I've been practicing for 26 years, and in 26 years I haven't been to one lecture on splints. And yet to me it's probably the cornerstone of dentistry in different ways. So I'm going to start just with a few questions, and you can just basically vote by raising your hands. But just out of interest, in this room, who would have been to a course just totally devoted, or a lecture totally devoted to splints since you've graduated? One. Okay. And then who would routinely use splints before embarking on, I'll call it phase 3 management or reconstructive phase management? Who would routinely use splints, for example, before they restored a mouth with implants? One? I like you. She's got good. Right. Who would use soft splints over hard splints? One. Righto. And, well, that next question's axiomatic, so I won't go to that. What about NITI, anterior splints, where we just use on anterior contact only? Any people in the room? One. Okay. And who would routinely prescribe a maxillary splint over a lower splint? So probably 50%. Okay. All right. Now, is Shireen Lim in the room? Very good, Shireen. So I'll come back to Shireen at the end of today. She's a good speaker there, Alex. One of your next lectures. So I've just dobbed you in, Shireen. Good. And also, who would routinely use face bows within their practice? Right. Okay. So this is good. So what I'm going to try to do for you is I'll just give you the way I'll go about this. Although I talked on some of these aspects last year, I appreciate there may be some people in the room who didn't listen to that lecture. And we do have a physio in the room, Lee Ray. And so I'll touch on a few things there for Lee. But you've got to have a few foundations. It'll be a bit like building a house. Otherwise, splint therapy, to get a grasp around it, can be very confusing. So I'll start from the basics. Some of it might be a little bit repetitive, but you'll need that information to understand the end game. So I'll touch a little bit again on sleep bruxism, because at the end of the day, in my book, that's probably what creates most of my work. And we'll certainly talk about how splints work, or how they think they work. We'll touch on requirements. We'll touch on the different types of splints. And when we're going to use those different types of splints. And then I'll also touch on a clinical protocol that I would routinely follow when I use splints. And I'll also, to give you some depth to my background, I've been fortunate in my career to have worked with good dentists, some really good dentists. So in my early days I worked with Peter McKerricker. Then I spent many years working with Bob Atinsky. And also I had the fortune of working very closely with Dave McNamara. So a lot of the information I'll deliver to you tonight is a distillation of those types of clinicians, but in particular the work of Dave McNamara. You all know Dave McNamara, or knew of him? Yeah, good. So he was a Perth prosthodontist who died a few years ago. So sleep bruxism, and I won't dwell on this. Whoops. Basically, it is just defined as a sleep-related movement disorder, and it is differentiated in sleep processes from a few other nasties. So we need to differentiate sleep bruxism from other things like faciomandibular myoclonus, which can be associated with sleep epilepsy and what's called REM sleep disorder. It's also implicated with things like dementia and Parkinson's. So when we're doing sleep studies and looking at movement disorders, it's very important that we differentiate from these other conditions that may have more sinister outcomes. And therefore it needs to be quantified. And in recent years, sleep bruxism has been very well quantified, largely through the works of people like Gilles Levine and Cato. And we understand that sleep bruxism predominantly occurs in non-REM stage 2, but it can be observed across all sleep stages. And there's lots of different figures that come out on prevalence, but I think it's fair to say that after 60 years of age, it does start to drop off a little bit. When Levine started their work on quantification of this in the early 2000s, it was largely because it was very difficult for them to compare studies. So we have all these different studies, but there was no common yardsticks to be able to compare one study against the other. So they largely set up these protocols, and through this then it's enabled more accurate studies to be provided, and we're starting to benefit from those sorts of studies now. I am personally one of those who do believe that sleep bruxism plays a very large part in airway maintenance. And there are other people who might think it doesn't. But largely how this came about was when they were looking at sleep bruxism. You know, in the old days we were taught that it was due to tooth contact that we bruxed our teeth. Largely through the work of these gentlemen, it came about that sleep bruxism really was more the result of motor activation than the cause of motor activation. And essentially it really became an amplification of a normal sleep process, what we call rhythmic masticatory muscle activity. And it was sort of deemed where we go from a deep plane to a lighter plane of sleep, we may or may not wake up. So that's called an arousal, or an arousal with awakening or without awakening. And we might clench our teeth very hard. The neck muscles will then contract against the masticatory musculature, and we might take a few gulps of air. And then we would then drop back down into a deeper plane of sleep. And this process was therefore perceived that it might really act as a fight and flight response to help maintain airway. And at the end of the day, without oxygen, we're dead in 3 minutes. So the analogy is we can go 3 weeks without food, 3 days without water, but 3 minutes without oxygen. And oxygen is something that we take for granted because it doesn't cost us anything, and you can't smell it and you can't see it. But it's a very, very pivotal part when it comes to patient assessment, is looking at oxygenation of the body and how oxygen is distributed. And that is brought through with our medical histories. Last year I touched on a fairly broad medical history that I use, but essentially within that medical history what I try to do is I break down the components of that medical history that draw my attention to these causes, or what we believe to be contemporary causes for sleep bruxism. So they basically break it down to psychosocial, neurochemical, sleep arousal. That's where the sleep disordered breathing comes in, and your restless leg, periodic limb movement, your REM sleep disorders, epilepsy, those sorts of things. That's all of arousal based. We can also have direct neurological input. That might be through trauma. It might be through a congenital condition like cerebral palsy. Genetics might play a role. We have direct inputs with neurochemicals. Inputs, so that's, the classic like nicotine and speed and all those sorts of things you see. And then you've got your psychosocial overlays there. And I think it's fair to say that in most patients that we see with bruxism, and we're going to be contemplating using splints, it's not going to be one thing. It's going to be a multitude of those things. And I work on the analogy of fire. The more sticks on the fire, the bigger the flames. And if we are able to work out what sticks we have on the fire and then take 1 or 2 of these sticks off, then the fire's not so big and we drop under the threshold and the patient becomes symptom-free. So you're never ever going to stop bruxism. It's always going to be there. We've just got to try and manage it. And it starts by recognising the cues. So when it came to quantification of sleep disordered breathing in particular, we have these 2 common indexes or indices that you'll come across. We have an AHI, which you would have seen before, and in particular we have the RDI. Now the RDI is the one that I'm interested in because of things called RERAs. And RERAs are something that have been a little bit swept under the carpet, in my opinion, in recent years, largely because there was a lot of confusion about them. There's a lot of confusion about the role they played. And it was also there's been lots of changes with quantification in sleep studies as well. But I think if you're looking at sleep bruxism in patients and you're going to start to get serious about it and you're starting to work out whether I make this patient a splint or do I do something else, the index you really want is the RDI. And you've got to align yourself with sleep physicians who do report with an RDI. And we're starting to see this more and more and more now, because a lot of the sleep physicians do start to appreciate that the RDIs, or the RERAs should I say, are becoming more recognised as playing a pivotal role in sleep bruxism. It's not the apneas and the hypopneas, it's more the respiratory effort-related arousals. And they're the under-the-radar stuff. They're the stuff that's not going to kill you, but they might be happening 200 or 300 times during sleep, as opposed to an apnea and a hypopnea that might happen only 10 or 15 times. And each event triggers an arousal, and each arousal results in a sleep bruxism. So I'm more interested in RERAs than what I am in an apnea or a hypopnea. And as I go along too, if you want to ask a question, you can. So feel free. The problem that I see with this, and this was something I've touched on with Ramesh Balasubramaniam, and I didn't get too far with him. But I think when you speak with different clinicians who have different aspects in dentistry, they look at dentistry in a different light. So in this room, with the exclusion of Lee, who's a physiotherapist, most of us are on the front line, we hold a handpiece and you're just sort of doing day-to-day general dentistry. Whereas when we look at maybe orofacial pain specialists, they are looking at patients in a different light, and so therefore they will be generally approaching their treatment in a different manner as well. And that's understandable. But since I became aware of this correlation between airway and sleep bruxism, it's one of those things you don't see until you start to look. And then when you look, you just think, wow, this is rife. And where it really comes to the surface is having a very comprehensive medical history. So there was a very good thesis that was done in 2011, 2012 in South Africa. And this was one of the pivotal pieces of research that really did show that sleep bruxism had a stronger correlation with an RDI as opposed to an AHI. And if you ever manage to come across that information, you read it. It's a very, very good thesis. So that's in 2012. So I look at AHI as a very poor surrogate for obstructive sleep apnea, and I probably prefer to call it that than sleep disordered breathing, because sleep disordered breathing has other areas. It includes things like central sleep apnea as well. So I think AHI, in my opinion, is a weak or a poor surrogate marker for obstructive sleep apneic events. And I think also you need to appreciate that when patients do have sleep studies, they're cross-sectional, and we have intra and internight variability. And so we just don't always look at a sleep study. We've got to look at the patient globally when we're working out where we go with them. So when it comes to the significance of sleep bruxism, again, a lot of this shouldn't be new, but essentially we're dealing with very high forces. So again, some people would say, Dave McNamara used to say to me, if you can bite as hard as you can and times it by 3, that's the sort of force that we might be playing with. And these forces are not instantaneous, they might be up to 15-second bursts. The clenches are what we call the silent assassin, because they make no noise. They're also often caused what I call the smiler of denial, because these are the patients who say, I don't clench, as they look at you. But you damn well know that they do. The other problem with it is the forces are usually off-centre. So high forces, increased frequency, off-axis, and of course what this does, it occurs at a time in our sleep when we have reduced reflexes, and this results in flexion and fatigue of teeth. Again, and I'll touch on this briefly, I won't go into it too much, but again, patients in my book with a history of dental intervention seem to be much more vulnerable to breakdown from sleep bruxism than patients with a history of minimal dental intervention. We'll obviously see the classics, the retrograde wear. We'll usually see the breakdown one side more than the other, a bit like being right and left-handed, and it usually affects the maxilla more than the mandible. And that's just differential in force. So the mandible can flex and dissipate force, the maxilla can't. It's bolted to the skull in 3 places, the teeth cop it. So we're largely looking at lines of force, teeth under lines of force, but don't forget the jaw joints. So I also spend a lot of my time looking at patients with jaw joint problems. And jaw joints, unfortunately, are overlooked. And tonight, what I talk on, we'll spend a fair bit of time looking at jaw joints and recognising that it's probably the jaw joint status that's really going to play the ultimate role as to what sort of splint you make. So when I look at a stable patient or a stable bruxer, these are patients that haven't had much done to them. And essentially the way I look at this is, teeth, jaw joints and muscles develop as a family. And if we're largely left alone, and I'm one of those, my parents couldn't afford braces or anything like that. I was an asthmatic, I've got a crossbite on one side. But, I grind like buggery, but I didn't have many fillings. I never had braces. My muscles and my teeth and my jaw joints and my musculature are all fairly well adapted. I do have to wear a splint, I have for 30 years. I'd probably have no teeth if I didn't. But largely speaking, these patients tend not to get too many problems with their teeth. That's my observation. And what I call about musculo-occlusal skeletal stability, and this is the concept of a dual bite. You're all familiar with dual bite? You understand what dual bite means? So there was a speaker, and his name was a guy called Bill Konkovich, and Alex might remember Bill Konkovich. He might have been in your year, Alex, was he? Bill Konkovich?